Today, we are talking about liver transplantation and images through ultrasound, and because it is not easy through questions. We have some numbers of hepatic artery. Very important resistance index should be between 0.55 to 0.80. Acceleration time less than 80 millisecond or 0.08 seconds. High systolic peak velocity should be less than 200 centimeter per second. Or we should interrogate all hepatic arteries, right and left, and main or proper hepatic artery. If there is a gradient of velocity more than 3 in different parts, it is very important. All branches should be interrogated. First gray, then Dopplers, color, spectral, and power for low, slow, or slow velocities. And sometimes we should use harmony for detailing and less noise. And we should change PRF for each vessel, color on every simple cyst, and we should forget simple cyst. We don't have simple cyst in a patient that has the transplanted liver. So we should forget it. It should be abscess. We should interrogate for dilated portal vein, dilated bile ducts, etc. This question, arterial tardus parvus waveform, means correct, proximal stenosis. Why we speak all the time about tardus parvus waveform? We have velocity, we have time, and because we all the time, most of the time, we can find a tardus parvus high diastolic, very long time for acceleration, a slow peak velocity, and then again high diastolic velocity. So we can't find the we can't find the point of uh, stenosis for sharp upstroke. It is the character of the point of stenosis. What we can have after stenosis and with this tardus parvus waveform. So low acceleration time is normal, but we have very high time to accelerate from here to here for the time to reach to the peak point. And positive high systolic with low diastolic flow, high, systolic is not high. And very important that tardus parvus is for collateral waves too. So collateral, maybe we have an occluded vessel, but because of the collateral, we see this tardus parvus waveform. So every time we see this pattern, we should interrogate a stenosis proximal to this point, before this point. You are doing a hepatic artery Doppler spectral Doppler in a first-day liver transplanted patient. Which one is more poor prognostic sign in the first day of operation? Is it with a very high resistant index, acceleration time 0.15 seconds, peak systolic velocity very high, more than 200, that is abnormal, Zero diastolic flow, it means it is with very high resistance. Which one in the first day of the transplanted patient is more serious? Correct. Acceleration time of 0.15. Why? Because it is a very prolonged acceleration time. So if we have this acceleration time, it is very prolonged, and so normal is 0.08 or 80 millisecond. So it is prolonged. It shows a tardus parvus and shows a real stenosis. But if we have high RI, is in most part of the hepatic artery, peak systolic volume, velocity more than 200 or zero diastolic flow, they are because of the hepatic um, edema due to surgery or transient ischemia. And the A, C, and D are abnormal, but they spontaneously resolve, and we should repeat our scan. Again, we have the same. You are doing a hepatic artery spectral Doppler in the first day liver transplanted patient. Which one is more poor prognostic sign in the first day of operation? A, RI 0.92, acceleration time 0.07 seconds, peak systolic velocity 39 centimeter per second with diastolic velocity 20 centimeter per second, sharp upstroke. Yes, correct. It is peak systolic velocity 39. Why? Because it shows the um, actually tardus parvus. Low peak velocity, diastolic velocity high, acceleration time here is normal. But with tardus parvus, acceleration time is high. Resistant index, if resistant index is less than 0.5, it is a disaster. But or sharp upstroke. Tardus parvus is not with sharp upstroke, a slow uh, going up, and so A, B is normal, A is high but transient in the first day, and D is transient, and we should repeat it again. So maybe the question is different, and we should know all of them. Why all the time we speak about the tardus parvus? Because we know that the point of stenosis is very small, and because of the gas and edema, we can't find the point of stenosis, but we can check the after stenosis, the tardus parvus effect, and all the time we should know that if we find a tardus parvus, it means peak velocity low and a very long acceleration time to peak systolic. Uh, all of them shows that there is proximal stenosis, and we can find a small stenosis. So repeating the ultrasound is very important, and follow-up in liver disease, both clinical and biochemistry, but most of the time, ultrasound can help us before the clinical or biochemistry appear. Why we have high resistance index in the hepatic artery in the first day? Maybe the donor liver is cold or edematous all around the liver or parenchyma, or old donor, more time for harvesting, Or we know here we have celiac trunk, then common hepatic artery here, and then celiac trunk left gastric, and then splenic artery. If the splenic artery uh, is more than 5 millimeter or 1.15 times the increase in diameter, it can cause Still syndrome. All blood goes here. A high resistance index in common hepatic artery, or even gastroduodenal artery dilated, like uh, splenic artery or gastroduodenal artery, both causes Still syndrome and ischemia to the liver with high resistance. So we should repeat the scan less than 24 hours. And the surgeons search for all these arteries and ligate or band them to prevent the Still syndrome, um, because it can cause ischemia and need for reimplantation. In a 3-week liver transplanted patient, there is a round anechoic cyst inside liver, gray imaging ultrasound. What is more suspected? So the patient with a liver transplant is a special patient with immunosuppression, many complications of bile ducts. So we should forget simple cysts. We should think about liver abscess, or if it is in the hilum, we should think about pseudoaneurysm the first days of transplant, or when we do the liver biopsy, or dilated portal vein due to AV malformation or dilated bile ducts. And because bile ducts is connected to the intestine, many organisms, for example, anaerobics or fungal infections, because these patients are immunocompromised, we should think all the time around this many important differential diagnoses. So we think about hematoma, hematoma more anechoic inside the liver, or like portal hepatis near portal vein, abscess, localized ascites, biloma means leak of bile acids from the duct because of ischemia, seroma, lymph fluid or lymphoma, non-Hodgkin lymphoma due to Epstein-Barr virus, infarction or focal liver parenchyma, recurrence of the masses, pre-existing masses, hepatocellular carcinoma, usually with pulmonary metastasis. So it is not only the liver ultrasound, it is checking all lymph nodes under the liver, between liver and kidney, portohepatitis or adrenals, spleen, mesentery, all should be checked for masses or lymph nodes. And for pseudoaneurysm, we should put a spectral on both sides. One may be 2 and the other A-way, yin-yang sign um, on the hematoma and the active port. Which liver transplant vascular complications is the most important to even need retransplant of the liver? Yes, correct. Hepatic artery stenosis. We know that for transplanted, the bile ducts only get the nutrient from hepatic artery, no superior mesenteric artery here. So if we have hepatic artery stenosis, we have ischemia of bile ducts, leak of bile that is very dangerous with abscess formation, high mortality rate. So it is the most important point that occurs between 2 to 12% of the patients after liver transplant. We have a portal venous stenosis or IVC thrombosis, but the most important thing is hepatic artery stenosis, and it is more common. And after 6 months, due to technical or due to neo-intimal hyperplasia. So we have portal venous stenosis. If it is earlier, it is technical, or it is later, neo-intimal hyperplasia, or because of catheter-guided angioplasty and then hyperplasia of neo-intimal. And lymphoma after 6 months because of immunosuppression and many viruses, or EBV or cytomegalovirus, all of them, especially EBV, can cause non-Hodgkin lymphoma. Bile duct nutrition and integrity depends on totally. Yes, hepatic artery, because the only artery after transplant is hepatic artery. No superior mesenteric artery for gallbladder or bile ducts. So a disaster is leak of bile into the liver, cause abscess because it's connected to the intestine, or bile is with enzymes that is very dangerous, necrosis, biloma, abscess, and high mortality. 5 months after liver transplantation, we have low velocity, less than 10 centimeter per second is low velocity for portal vein. Which choice is correct if you suspect portal venous thrombosis? Yes, power Doppler we should use all the time. Power Doppler to find slow flows and the thrombosis, expansion of thrombosis, partial or total, or differential diagnosis. And if we have anechoic portal vein, it doesn't show that it's patent. And sometimes it is not for permanent, it resolves spontaneously, and the hepatofugal flow is abnormal, so it shows maybe collateral or um, stenosis of the other branch. For stenosis, we had um, before 6 months and after 6 months, two different etiology. For after transplant, if we have normal portal flow, a slow flow is always after transplantation. Um, the first days it is normal, and thrombosis occurs 1 month after transplantation. Power Doppler is necessary, and the stenosis occurs after 6 months later. Gradient velocity in different parts, right and left, and main portal vein 3 to 1. Maximum velocity more than 155. All shows portal venous stenosis. Flow direction, hepatofugal or from collateral, is abnormal. Always thinking about a hematoma that is compressed, the portal vein, and compression effects needs evacuation of the hematoma, especially when they are larger than 5 centimeter. So a slow flow less than 10 centimeter per second in portal vein in the first day after surgery is normal due to parenchymal edema. We should repeat it. We shouldn't think that is normal, but we repeat it for coming up and upper to about 30 to 40 centimeter per second. Or if it persists, it shows varices coronary left gastric vein near the esophagus or gastric that causes hematemesis, thrombosis, cause a slow flow, or external compression due to hematoma. We see a dilated, dilated portal vein, dilated portal vein that is pulsatile on spectral. It is pulsatile like hepatic vein, but we know that hepatic vein is here. Okay, pulsatile and dilated. Um, we should think about, yes, AV fistula. If we do the biopsy, AV fistula or pseudoaneurysm may occur as a complication. So here we think about AV fistula, and so the size is very important, and then the size is very important, high flow and pulsatile. It is the fistula with hepatic artery. Hepatic artery here low resistant, but if we have a Still syndrome from the splenic artery, it causes hepatic artery high resistant. And history of biopsy should be verified. Aliasing at the site of fistula, different flow direction in the draining vein that is dilated. And please remember that resistant index in splenic artery Still syndrome in hepatic artery is high, but here is low. The is the most malignancy in post-liver transplant. All solid tissue transplant is with skin squamous cell carcinoma and also non-Hodgkin lymphoma because of Epstein-Barr virus. And these carcinomas, these tumors and Kaposi sarcoma of the skin too, but skin squamous cell carcinoma is more common. If we see a liver parenchyma that are heterogeneous, which choice is being suspected? Yes, it is hepatic artery stenosis or ischemia, recurrence of hepatitis C or CMV infection, rejection. The only sign of rejection in ultrasound can be only heterogeneous parenchyma with abnormal biochemical tests, and around hepatic artery we have infarction and ischemia heterogeneous and no flow on power Doppler. And sometimes reperfusion injury shows a little bit like collaterals. Free fluid in the first days, pleural effusion, especially right pleural effusion, it is small and without any clinical symptoms like dyspnea, tachypnea, or hypoxemia. It resolves spontaneously. So don't forget about the fluid, especially in the bare lobe of the liver. So please interrogate all parts of the liver.